Okay, good afternoon, my friends. I am going to be giving you lecture 19 and lecture 20 today. Lecture 19 and 20 and 21 all are related to the collection and analysis of body fluids. So we're talking about things like spinal fluid, pleural fluid, synovial fluid, seminal fluid, etc. So we're beginning our lecture on the laboratory analysis of body fluids unit. Now, sometimes you will get tubes and sometimes you will get gallons. So some fluid collections, like some pleural fluid collections, for example, will come in large containers. So it's really important to know the specimen and what needs to be done for each of them. So on the left in this image, we see a spinal fluid collection, and you'll get several tubes. And on the right, we have a collection of ascites or peritoneal fluid. So again, we could get something in a gallon jug at times, depending on the fluid type. So because of this, it presents a challenge to the laboratory and sometimes involves multiple departments when we talk about body fluid analysis. So hematology is our end of the deal, is looking for cells or crystals. Some of the other departments like microbiology will look for bacteria or other infectious agents. Chemistry will do chemistry analysis, looking at glucose levels or protein levels. So the hematology laboratory usually receives fluids for cell counts and morphological evaluation. We're looking for types of cells, and if they are found, we need to concentrate them and identify them, and that's going to help give information to the clinician in arriving at some kind of diagnosis for the patient. Cells can be found in these fluids anywhere from white blood cells, red blood cells. Sometimes we'll see tissue cells, and sometimes we can actually see tumor cells. So in synovial fluids, we may also look for things like crystals. So identifying and differentiating the types of cells seen in body fluids requires experience. All lab techs who perform body fluid analysis need to be able to differentiate the types of white blood cells, normal tissue cells, normal tissue lining cells, and most malignant cells from benign cells. Chemical analysis again involves things like glucose content or protein content. For example, spinal fluid, the glucose and protein content is important, and that can be an indicator of the presence of a potential organism in the sample as well. Microbiology and immunology are going to detect infectious agents by doing gram stains and cultures. Unfortunately, culture is not a stat thing, but we want information right away from something like a spinal fluid. So gram stain is one of the most rapid tests we do in microbiology. And then looking for any tumor cells or abnormal cells that might be present. Pathologists or cytologists will then be given the sample for a definitive diagnosis. So body fluids are assessed to determine the presence of inflammation, infection, malignancies, hemorrhage. So they're important specimens that are collected and analyzed in the lab. So body fluids, other than urine, are not easily obtained. Collection of specimens requires insertion of needles or catheters. So there are some risks involved to the collection of body fluids. Some samples may be small in volume and very fragile. For example, spinal fluid, cerebrospinal fluid. So they need to be handled with care. We don't want to have to go recollect a specimen. a lot of times that's just not able to be done. So we have to be very careful with how we handle the specimens. We offer tests on these body fluids, and we have to be able to provide accurate and timely results. Normal values, reliability of the results, and proper specimen collection and handling is really key when we talk about body fluid analysis. So depending on the physician's reason for collecting the body fluid, the examination typically involves evaluation of the fluid's physical characteristics, color, clarity, chemical analysis, microscope review of cells or any other morphological elements, as well as culturing for microorganisms. Special studies may be done in-house or sent to a reference lab. When we talk about the central nervous system, fluid that we are talking about here is cerebrospinal fluid. Just a quick overview of the central nervous system anatomy. We have the brain and spinal cord, which are surrounded by protective coverings called the meninges. The outer layer, or dura mater, the middle layer, or arachnoid mater, and the inner layer, or the pia mater. Cerebrospinal fluid is produced by a group of cells in the central brain regions called the choroid plexuses. And that cerebrospinal fluid is an ultrafiltrate of blood plasma. We find these choroid plexuses in 4 ventricles in the brain. And the cells that produce them are called ependymal cells. The cerebrospinal fluid in adults is produced at about a rate of 20 milliliters per hour. So it's flowing through the subarachnoid spaces, and the approximate volume in an adult is about 90 to 150 milliliters. And when we're talking about neonatal specimens, we only have about 10 to 60 milliliters. So again, collecting a specimen, especially when you see it's a child, you have to be very careful not to damage that specimen, because recollection is not an option. The cerebrospinal fluid is reabsorbed in an area of the brain called the arachnoid villus, and that is eventually reabsorbed into blood. So the production and the reabsorption of cerebrospinal fluid is a very fine balance. Pattern of flow is shown in a drawing from a book called Stassinger's Reference, 6th edition. And you probably have all seen this picture in your anatomy books when you took anatomy and physiology. Cerebrospinal fluid is the 3rd major fluid of the body. Others that we would deal with are blood, urine, and those are numbers 1 and 2. So amounts of cerebrospinal fluid, again, 90 to 150 milliliters in adults, 10 to 60 milliliters in neonates. The blood-brain barrier is a secure barrier between blood and cerebrospinal fluid. Again, that spinal fluid is sometimes described as an ultrafiltrate of blood. That blood-brain barrier is extremely important. It's basically the cells being extremely picky as to what they will remove from blood plasma. And that's to protect the brain from any chemicals or other harmful substances that may be floating around in the circulatory system. So in this process, antibodies and medications can also be blocked. It's one of the hardest things to overcome when you are producing a drug that you would like to target cells in the brain. You have to overcome the blood-brain barrier. So testing for these substances that are normally blocked can be helpful in diagnosing patients. If the abnormal substance is at a high enough concentration in the cerebrospinal fluid, it might indicate some sort of disruption of that blood-brain barrier. And again, the blood-brain barrier is protection for the brain cells. So in diseases like meningitis, where you have an inflammation of the meninges, or multiple sclerosis, we might see substances in cerebrospinal fluid that we normally shouldn't. So due to the blood-brain barrier, CSF composition is very different from that of plasma. So according to these notes, cerebrospinal fluid is not an ultrafiltrate of plasma because it is so different from blood plasma. So, given those four major categories of disease, cerebrospinal fluid is analyzed to confirm diagnosis of meningitis or to evaluate an intracranial hemorrhage or to diagnose malignancies, or it can also investigate central nervous system disorders. So when a physician decides CSF testing is needed, CSF specimen collection and handling is extremely important. CSF is a precious specimen and not easily obtained or recollected, and can be very painful for the patient to collect. CSF is routinely collected under sterile conditions, lumbar puncture, and we're going between the third and the fourth, or the fourth and the fifth lumbar vertebrae, because the spinal cord ends higher in the lumbar region. We don't want to poke a needle into your spinal cord. What we see in these lower lumbar regions are groups of nerves coming from the lower extremities. Once the puncture has been made, the first step is to measure the intracranial pressure. Too much fluid floating around in these closed cavities can create too much pressure in a person's central nervous system, and this can cause a lot of trauma. So once a puncture has been done, we have to check for that pressure. A low pressure can be seen in trauma where there's been a loss of cerebrospinal fluid, and an increased pressure is diagnostic of intracranial hypertension, or too much pressure in the central nervous system. And that's present in a lot of different physiological states, including tumors or intracranial bleeding. Meningitis can also present with a high pressure. So when we collect cerebrospinal fluid, it's removed and collected into a series of tubes, and the tube number is extremely important. So tubes are numbered to indicate how the fluid was removed, and the first fluid that is removed will go into tube 1, the next amount of fluid in 2, and so forth. So usually 3 tubes are collected, but sometimes we'll see a 4th tube. The first tube typically goes to chemistries and serology. second tube, microbiology, third tube, hematology. If there is a fourth tube, usually the first tube is set aside. Number 2 then becomes number 1, number 3 becomes number 2, and so forth. So the goal is to have the hematology be the last sample that's removed, so that cells can present, cells that present within the tube can definitely be said to have come from the spinal canal and not the result of a traumatic tap. I might have to kill my dog in a minute, so. All CSF testing is considered stat. So we don't want those tubes lying around at all. And need to always keep in mind that cerebrospinal samples are potentially infectious as well. So we want to process these specimens in a biological safety cabinet. So the gold standard for CSF testing is to perform it stat, and that's within an hour. If immediate processing and testing isn't possible, tube 1, the chemistry and serology, can be frozen. Tube 2 for microbiology should be kept at room temperature, and tube 3 for hematology can be refrigerated. But again, ideal, we want them done within an hour or stat. So this is an example of looking for cloudiness in sample. So initial analysis, color and appearance is important. CSF is normally crystal clear and colorless. So on the right-hand side, we have a normal CSF, where on the left-hand side, we see there is some turbidity here. So when its appearance is not clear, we need appropriate descriptive terms to describe what it looks like. So hazy, cloudy, turbid, milky, bloody, xanthochromic are all terms to describe the appearance. When the non-clear terms are used, they may be semi-quantitated. So we can see in a designation such as slightly hazy or moderately cloudy or grossly bloody. Specimens that are not clear may contain increased lipids or proteins or cells or bacteria. So the picture shown here is putting print paper behind the CSF. And that's going to help you actually see clearly what the clarity of a specimen is. The cloudy sample is often an indication that it contains white blood cells, and it would be seen in meningitis. So color is also important. Xanthochromic or yellowing could be pinkish or orange. And we see in this specimen on the left, you can see it better on the bottom of the tube in this particular image. It has a yellowing color to it. So xanthochromia is a yellowing discoloration of CSF supernatant. Could be pinkish or orange. Xanthochromia, and this term is typically only used for CSF specimens. It may be due to the presence of old blood, maybe the result of an increased bilirubin or an increased carotene. Other reasons may include proteins or melanoma. So again, xanthochromia usually indicates old blood or bilirubin. Clots in cerebrospinal fluid may be indicators of increased fibrinogen, usually due to a traumatic tap, but may indicate damage to the blood-brain barrier. Specimens that are not clear may contain increased lipids, proteins, cells, or bacteria. A milky appearance of CSF likely contains increased lipids. An oily appearance to CSF is sometimes seen in samples that are contaminated with different X-ray dyes or contrast dyes. We also can have pellicle formations or web-like clots, and that can form following refrigeration. It is also seen in tubercular meningitis as well. When blood is found in CSF, it is helpful to determine whether the blood's presence is due to trauma during the collection, also called a traumatic tap, or if it's due to cerebral hemorrhage. So the characteristics of cerebral hemorrhage include even distribution of blood in all of the numbered tubes. So the picture on the left represents two consecutive CSF tubes that were collected. And you can see here that both appear to have a similar amount of blood in them, as would be seen in a cerebral bleed. If there is sufficient blood and fibrinogen present, clots may be seen. After spinning CSF sample in the centrifuge, xanthochromic yellow supernatant will be seen in patients with cerebral bleeds if enough time's gone by for the red blood cells to degenerate. So typically red blood cells must have been in CSF 2+ hours before we see xanthochromia. Serological tests for D-dimer for fibrin degradation products from the hemorrhage site may also be helpful information to help us support the diagnosis of an intracranial bleed. On the microscopic differential, we may find erythrophages, macrophages that have ingested red blood cells, and hemosiderin granules indicate intracranial hemorrhage and not a traumatic tap. So traumatic collection may be, I don't know, a false indicator of cerebral hemorrhage. Again, if we see the first tube has blood in it and then the others don't, that is a clear indication of traumatic tap. We know our wonderful chamber that we were used to or used in our white blood cell counting lab is also used for cerebrospinal fluid procedures. So all CSF specimens should be examined microscopically, looking for cells. And again, this is usually performed by the hematology department. CSF samples must have stat priority because red blood cells lyse within an hour. White blood cells lyse within 2 hours. So hematology samples should be refrigerated if we're not able to process it immediately. Manual cell counts are needed because the numbers of cells present are typically too low to be counted accurately using automated cell counters. Although nowadays more and more instruments are becoming more and more sensitive, and we might see that definitely change in the future. Rarely is a dilution needed, but if a dilution is needed, it should be in normal saline. The counting is performed in a standard Neubauer hemocytometer counting chamber. Again, this is the same counting chamber we saw when we did our manual white blood cell counts. Red blood cells and white blood cell counts are reported as numbers of cells per microliter. We can see our map here that should look very familiar. Average number of cells counted. We're going to average the two sides. The dilution factor. In this case, typically we do a 1-to-1 dilution, so this number will be 1 unless needed to make a dilution. So we'll use, the number will be 1 if we use straight fluid, and a 1-to-1 dilution if we have to dilute. So dilution factor, again, this number for CSF is typically 1. The volume correction factor represents the total volume of squares counted in terms of 1 microliter. So that's the same as we saw previous. And the volume counted, we're going to be looking at the width times the height times the depth times the area. So you should learn and know common volume correction factors. Remember that the volume correction factor is dependent on what squares were counted. So if we count all 9 squares, or if we count just the 5 squares in the middle square, or if we count 4 squares on the 4 corners. So if I count the 9 squares, the volume correction factor would be 1.1. If I count the 4 corners, the volume correction factor would be 2.5. And if I count the 5 small squares within the center square, the volume correction factor would be 50. So all 9 squares, we get the volume correction factor by multiplying 1 times 1 times 0.1 times 9. That gives us 0.9 millimeters cubed. And the volume correction factor would be 1 microliter divided by 0.9 microliters, or millimeters cubed. And that would give us the 1.1. So the volume correction factor for the 4 corner squares, 1 millimeter times 1 millimeter times 0.1 millimeter times 4. That would give me 0.4 millimeters cubed. And again, millimeters cubed can also be written as a microliter. And the volume correction factor for the 4 corners would be 1 microliter divided by 0.4 microliters, and that would give me my 2.5. For the 5 small squares from that center square, red blood cells is what we're going to be assessing there, volume correction factor would be, because we're looking at the smaller squares now, 0.2 millimeters times 0.2 millimeters times 0.1 millimeters times 5. This would give us 0.02 millimeters cubed. And again, another way to write that would be microliters. So our volume correction factor for the 5 small squares would be 1 microliter divided by 0.02 microliters, and that is how I get my 50. So normally we don't find any red blood cells in cerebrospinal fluid. The normal value and type of white blood cells is dependent on the patient's age. So adults up to 5 mononuclear white blood cells per microliter is normal. Newborns up to 30 mononuclear white blood cells per microliter is normal. children, ages 1 to 4, we can have up to 20 mononuclear cells per microliter, and 5 years of age up to 10 mononuclear per microliter. Pleocytosis is a term used to indicate an increased number of normal cells. You can have a neutrophilic pleocytosis, lymphocytosis, or lymphocytic pleocytosis, mixed cell pleocytosis, etc. So if there's too many red blood cells present to get an accurate white blood cell count, you can go through the lysing process that we practiced in lab. So we lyse the red blood cells with a 3% acetic acid, and then we can use a methylene blue stain. That'll also help improve the visibility of cells. And if using a stain or lysing the red blood cells with acetic, we have to be sure we keep track of the dilution you are making to account for it in your calculation. So on occasion, you may be asked to correct the white blood cell count for traumatic tap contamination. I'm mentioning this because be warned that there are too many variables and assumptions that have to be made that it would mean there is a considerable chance for error when we talk about correction for white blood cell. So before doing such a correction, consult with the department head and pathologist. He or she may want to consult with the attending physician to make them aware of the error that is possible, as the more appropriate process would be to have a sample recollected, unfortunately. In this case, it uses ratios of white blood cells to red blood cells in blood and compares it to same ratios, white blood cells to red blood cells in CSF. If the patient's peripheral cell counts are normal, we can subtract 1 white blood cell for each 700 red blood cells counted in CSF. There's a great chance for considerable error, and it makes this correction requests really of little value. Now, quality control samples produced by QCing body fluids is important. Manufactured CSF controls should be used regularly to verify the accuracy of the techniques that are being used, and by any laboratory staff who are performing these cell counts. Controls also check the acceptability of any reagents or diluents, and centrifuges also have to be QC'd as well. A special safety reminder: since CSF can transmit virulent pathogenic organisms, it is necessary to decontaminate all counting chambers in bleach and water for about 15 minutes. Rinse in water and cleaned again with alcohol. They have to be dried carefully and stored in a proper container that'll prevent the chamber from being scratched. At Maine General Medical Center, we use disposable hemocytometers for body fluids because of this. After the cell count, we do a differential on the cells in the CSF. Because of the low number of cells, it's necessary to concentrate the sediment by spinning it down in a special centrifuge called the cytocentrifuge. And during the centrifugation process, the CSF is filtered through a membrane, and that membrane is going to capture cells. While the centrifugation process concentrates and increases the number of cells to evaluate. The process can cause distortion of the cells as well. Most procedures add a small amount of albumin to help reduce cell damage and distortion. So the membrane is then mounted on a microscope slide and stained with Wright stain. And you can see an image here of the Cytotech cytocentrifuge and the assembly used for concentration of centrifugation. So after staining the slide with Wright stain, you count and differentiate 100 nucleated cells, just like you do in a peripheral blood smear when you're doing a white blood cell differential. So keep in mind that 0 to 5 white blood cells per microliter is normal for adults and 0 to 3 for children. So sometimes finding 100 nucleated cells is difficult unless the patient has pleocytosis. Any cell found in peripheral blood may be seen in CSF as well, as cells from the tissue forming the membranes. So typically you are going to find lymphocytes, perhaps a few monocytes, macrophages, a rare neutrophil in normal patients. The published normal CSF differential values for adults are 70% lymphs, 30% monos, while children and newborns should only have monocytes. If the patient has a central nervous system malignancy or a leukemia, these abnormal cells may be discovered in CSF as well. Ependymal cells and normal cells that line the central nervous system may also be seen in CSF. So after obtaining the 100-cell differential, the entire smear should be evaluated for abnormal cells, any inclusions within the cells, or the presence of any intracellular organisms. And we see some intracellular organisms here in this picture. So these are some examples of what we might see in cerebrospinal fluid. Lymphocytes and macrophages here, monocytes, macrophages, neutrophils, and lymphocytes can be seen here. So here's a portion of a lymphocyte. We see neutrophils, macrophages, monocytes are these cells here. Eosinophils are occasionally seen in CSF and often are associated with parasitic or fungal infections or allergic reactions, reactions to things like shunts and other foreign objects that might be inserted into the central nervous system. So here we see eosinophils. Not the arrows are not pointing to eosinophils in this image. The eosinophils are beside these cells. Those are lymphocytes. And we can see a bunch of eosinophils here as well. Remember, eosinophils have those orange granules. Ependymal cells are unique to CSF samples as well. They're normal cells, but not often found. These cells line the ventricles and are responsible for producing cerebrospinal fluid. And again, they're in such small numbers, it's hard to find them. Ependymal cells are one of the larger cells that you may find in cerebrospinal fluid and are identified by their distinct round oval nucleus and the large amount of cytoplasm. A lot of times, or sometimes, when you do find them, they're seen in sheets of cells. as we see down here on the bottom image. This one is textbook ependymal cell here with a nice round nucleus and lots of cytoplasm. The cells in this and the next slides are examples of some what we call suspicious or malignant cells, and as sometimes seen in cerebrospinal fluid, we can find these samples. Not designed to give you knowledge and skills of cytologist, however, the MLT should be expected to recognize abnormal cells that do not fit the pattern or characteristic of our normal white blood cells and ependymal cells. So even though we might not be able to identify these cells, we should recognize that they are not our normal cells found in cerebrospinal fluid. According to the protocol of your clinical facility or future workplace, you would classify or call these cells suspicious or unclassified. And then the slide has to be brought immediately to the attention of the department supervisor or cytologist or pathologist. Again, you have to follow the protocol of the clinical facility that you are at. So looking at these guys, we don't see any of those familiar cells that we would see in a normal differential or normal cerebrospinal fluid. Macrophages, by definition, are big eaters, and they are differentiated monocytes. That is, they are the result of a changed monocyte. So both monocytes and macrophages are phagocytes. So their role is to engulf and digest cellular debris or foreign objects. So a macrophage that has engulfed a red blood cell is more appropriately named an erythrophage. And we can see that in this image at the top right. As the digestion of red blood cells takes place, the erythrophage becomes a siderophage, and we see siderotic granules here in the lower right. So this is after engulf and after digest. When the digestion process has continued further, all that remains is the indigested bilirubin crystal. Also called hematoidin crystal. And again, we see that here in this image on the lower left. So this indigestible, or indigestible, I guess is the right word, bilirubin crystal can be seen here as the cell ages. So there are commercially prepared quality control samples that should be analyzed in parallel with the patient's CSF. Labs have special CSF QC for cell counts and chemistry testing. So all covered previously, the blood-brain barrier causes a selective filtration of plasma, giving us the CSF fluid, which is a unique, which will have unique sets of values for many chemical analytes. So therefore, the CSF normal values for chemical analytes is different than the chemical analyte normal values of plasma. Abnormal values of CSF analytes are the result of an altered permeability of the blood-brain barrier, or they could be a result of increased production or increased metabolism of an analyte. So there's a special CSF QC for chemistry tests. The ranges can differ or be very different from the plasma or serum values. So you can't just have the same normal value charts that you do for plasma. Cerebrospinal fluid proteins. The first of the CSF chemistries that is typically tested is for protein. So CSF protein normal value is low compared to serum or plasma. CSF protein normal range is between 15 and 45 milligrams per deciliter. Serum protein is reported in grams per deciliter and usually ranges from 6.4 to 8.3 grams per deciliter. So we're talking about milligrams per deciliter. In normal situations, albumin is the only protein fraction found in CSF. Presence of IgG globulin fraction brings about the concern of whether it came from a damage in the blood-brain barrier or whether it was produced within the central nervous system itself. Protein electrophoresis is going to be important here, and it is one method used to identify the presence of an oligoclonal band, meaning few or small clone, or a malignant band. Decreased levels of CSF proteins aren't typically significant. The concern is finding an abnormally increased protein level. Damaged blood-brain barrier, as in meningitis or hemorrhage, can increase protein levels. Productions of immunoglobulins within the central nervous system. An example of that might be multiple sclerosis can increase protein fraction. CSF protein is best measured by a dye binding method. The alkaline biuret procedure has been used, but another one that can be used is something called the Kamasi Brilliant Blue procedure, and this one is a preferred procedure. So in this procedure, a blue color produced is measured with a spectrophotometer, and we determine the amount of protein using Beer's law. Multiple sclerosis is an autoimmune disease, and that affects the central nervous system. Symptoms can vary from numbness, weakness, vision problems. All right, sorry about that. All right, so multiple sclerosis is an autoimmune disease. Again, symptoms vary: numbness, weakness, vision problems, tremors, slurred speech, fatigue, dizziness. Episodes can last for days, weeks, or months. In between attacks, patients may have few or no symptoms. Typically, we see symptoms when patient is relapsing or out of a remission cycle. Symptoms typically worsen, and shorter remissions are going to be seen as the disease progresses. So diagnosis of MS is difficult and often is made after everything else has been eliminated. Some laboratories offer a multiple sclerosis panel of tests, and it can be used to help support the clinical findings, patient history, and other data. So for most of the analytes tested, we must test both serum and CSF in parallel. In electrophoresis, there's a direct comparison where we look for oligoclonal bands in the CSF that aren't present in the serum. On the right-hand side, we can see those bands with the arrow pointing to them in the CSF. So myelin basic protein is an abnormal protein, and its presence indicates the demyelination of neuron axons. Comparison of the serum and CSF levels of albumin and IgG can also provide useful information in making a diagnosis and monitoring the progression of MS. The formula on the slide is used to calculate the IgG index. Normal is considered less than 0.77. So again, we can see CSF IgG levels, serum IgG levels, CSF albumin levels, and serum albumin levels in this calculation. So again, having to be analyzed side by side. So a normal CSF will have the absence of those oligoclonal bands, and we see here an abnormal CSF with the presence of the oligoclonal bands. So the next CSF chemistry done is typically a glucose level. Glucose is selectively transported across that blood-brain barrier. Normal CSF glucose is about 60 to 70% of the patient's current blood glucose. So again, typically blood is collected and analyzed as well. So an example, if we have a blood glucose of 100, CSF glucose usually runs between 60 and 70. So it's very important that CSF glucose be analyzed quickly. If organisms are present, if there are any organisms present, or if there are any cells present in the CSF, the glucose will quickly reduce. So when testing patients' blood glucose, we should also be testing in parallel the CSF to provide those reference ranges or expected values. The CSF glucose procedure is performed in the same manner for blood specimens. Decreased levels of CSF glucose are part of the hallmark findings seen in bacterial and fungal meningitis. A patient who's hypoglycemic or has a low blood sugar will have low CSF glucose. Also, reasons for decreased CSF glucose include brain tumors, leukemias, as a result of central nervous system damage. Another chemistry test that can be done on CSF is lactate. CSF lactate normal values are 11 to 22 milligrams per deciliter. Increased levels occur as a result of hypoxia or low oxygen, as can be seen in cases of bacterial meningitis or head injuries. I want to kill my dog right now. I'm going to have to pause and come back. All right, let's try this again. So we were talking about lactate levels and their normals. Hypoxia, we're going to see an increased. Measuring those CSF and blood lactate levels in parallel is also going to help in the differentiation between bacterial and viral meningitis. So repeat testing is useful in determining whether a treatment or therapy is effective, and we'll see the lactate levels return to normal quickly if the therapy is effective. Hemolysis or xanthochromia will cause an increased lactate result. Glutamine is another chemistry test performed on CSF. Increased levels above the normal 8 to 18 milligrams per deciliter is associated with ammonia in the CSF, and ammonia is a toxin. Glutamine is produced from ammonia and alpha ketoglutarate by the brain cells. And this process removes ammonia, which is a toxic metabolic waste product from the central nervous system. So as the concentration of ammonia in the CSF increases, the supply of alpha ketoglutarate becomes depleted. Glutamine can no longer be produced to remove the toxic ammonia, and a coma may result. So CSF glutamine test is frequently requested for patients with coma of an unknown origin. This is one of those handy dandy little charts. It's been consolidated to help you consolidate your notes. So into the table, the typical lab results you see with different types of meningitis. Spend some time looking over this chart, and that can help you compare the various lab results seen in bacterial, viral, tubercular, and fungal meningitis. So direct CSF gram stain is extremely important for early detection of organisms that are common causes of meningitis in newborns, children, adults, and immunocompromised patient populations. All smears should be performed on concentrated cytospin specimens because, again, only a few organisms are present at the onset of disease within the cerebrospinal fluid. Even with concentrated specimens, at least a 10% chance exists that gram stain will be reported as negative. So cultures are done in conjunction. Cultures are always set up at the time gram stain is performed. So here's a list of organisms that are common causes of meningitis in newborns, children, adults, and immunocompromised patient populations. So these are some of the things that might culture up for you. E. coli, group B, strep in newborns. Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitidis in children, Neisseria meningitidis, Streptococcus pneumoniae, Staph aureus in adults, and then we will also see Cryptococcus neoformans, Candida albicans, those groups of organisms in immunocompromised patients. Kind of an outdated test that is performed is something called the India ink stain. Excuse me. India ink stain or nigrosin stain prep. This stain prep is used to identify Cryptococcus neoformans. Once relatively rarely encountered, this organism is commonly found in the CSF of patients who are immunocompromised. So with the coming of AIDS and immunocompromised patients, we're starting to see more and more of this organism in CSF. Cryptococcus organism is surrounded by a capsule. So this staining procedure allows you to visualize that capsule. When the specimen containing the organism is mixed with the stain and viewed under the microscope, it can be seen or detected by how that capsule pushes away the stain particles, making the organism appear to glow in the center. The same effect can be achieved by using dark field microscopy. instead of the negative India ink or nigrosin stain. Because these direct procedures only have a 25 to 50% sensitivity, latex agglutination tests are performed nowadays and are more sensitive. Serologies. VDRL test is used for the preliminary detection of neurosyphilis. This test has low sensitivity but high specificity. And that means that it may not detect all cases, but a positive result is a true positive result. Some other serological tests are for syphilis, and we find that test the FTA-ABS, and that stands for fluorescent treponemal antibody absorbed, which is used to detect antibodies to Treponema pallidum. That's the organism that causes syphilis. This test's more sensitive than the VDRL, but its use to diagnose neurosyphilis is still controversial, and it is extremely sensitive to the effects of contamination with blood. So FTA-ABS is used on CSF, and it's more sensitive, but you need to be sure to prevent any blood contamination of that CSF sample. Again, FTA-ABS is fluorescent treponemal antibody absorbed. And finally, a few comments about the future of cerebrospinal fluid testing. PCR, or polymerase chain reaction testing, is being rapidly developed, and that's going to help to aid in the diagnosis of meningitis. PCR brings to the table both high sensitivity and specificity in the detection of many viral, bacterial, tubercle, and fungal organisms seen in CSF. So when compared to the standard procedure, PCR testing is fast and can be done with small volumes of CSF, which is important because of the fact that we only get a small volume. Also, PCR testing is expensive, unfortunately, and there is potential for cost savings by decreasing overall diagnostic testing. May also mean saving patients' lives because appropriate therapy can be started much faster. So PCR is currently useful in diagnosing viral meningitis caused by EBV or CMV and tubercular meningitis. Bacterial meningitis. They're currently studying and developing more test specifics for bacteria. That is the end of 19. Hope you guys had a happy Thanksgiving, and I will see you on Thursday.